Good morning. My name is Dr. Jolanda Appelman. I'm an interventional cardiologist from the Amsterdam University Medical Center in the Netherlands. My talk today is about the first ECG within 10 minutes and then what? And I'm very pleased to give a presentation today at the ESC Digital. Of course, we all know that it's very important to have a quick time between patients' complaints and arrival at the cath lab. Time is muscle, and ischemic time duration is the major determinant of infarct size. So early recognition and early management give reduction of morbidity and mortality of patients with a STEMI. In this, regional cardiac emergency systems are very important. However, until now, the main focus on time management in journals has been on the door-to-balloon time. However, there are different components of ischemic time. You can appreciate here the STEMI guidelines of 2017. We have, of course, patients with complaints. Before they call to the ambulance, we have the patient delay. Then we have the system delay, which consists of the emergency medical system. The ambulance is arriving here at the patient, and then within 10 minutes an ECG should be performed, should be sent to the primary PCI center, and the diagnosis should be made by the fellow or by the cardiologist. And then it's important that the ambulance is driving to the primary PCI center so that within 90 minutes reperfusion is there in the patient with a blocked artery. So this time, the system delay is very important to make it short as possible, because there are several factors influencing the system delay. And it's important to take notice of this, because the regional cardiac network systems have to provide optimal care. So EKG interpretation is very important. Bypassing non-PCI hospitals to a 24/7 availability of a primary PCI center is important. Of course, of influence is if the patient is hemodynamic stable, no shock or no out-of-hospital cardiac arrest, because this influences the time. Furthermore, presentation in off or on office hours is also of influence, and gender seems to influence the delay between chest pain and arrival at the PCI center. This is demonstrating a very important paper that demonstrates the impact of system delay, the FIT-STEMI trial, which is a large German trial, which included almost 13,000 patients. Most of the patients, almost 11,000, are without shock or without out-of-hospital cardiac arrest, and the rest is divided in the three other groups. And you can appreciate that different drivers of contact to balloon time, we know that they are patient-related, but we also have to take notice of the performance-related parameters, because they are very important in system delay. So if the presentation, for instance, is in off hours, you can see a delay of almost 8 minutes for patients to arrive. Furthermore, if there's a pre-hospital EKG made, or if the EKG is made within 10 minutes, pre-announcements by telephone or direct transmission to primary PCI lab, then you can reach a reduction in time of more than 33 minutes. So it's important, because we know that the contact to balloon time will give influence on the mortality, which is demonstrated in this slide. This is the total patient cohort, and this is the mortality on the y-axis. And you can see that for all the different cohorts, this is the quite normal population, STEMI population, and that every minute counts, because every rise in delay will give an increase in mortality. So that's important. Second, is it important and of influence if the patient is presented on or off hours, office hours? Well, there's some contradiction in this. Some studies mention, yes, it is important. Others say, well, it doesn't matter. There's no difference. So this systematic review published a few years ago is very important because it demonstrates that it is important with an odds ratio of 1.06, a higher in-hospital and 30-day mortality for presentation of hours. Furthermore, it is demonstrated that it's important that there's less timely reperfusion, so it is standard patients are not treated within the 19 minutes after the ECG is made. So pre-hospital triage and ambulance personnel should be aware of this. Furthermore, of course, not every ECG has a typical ST elevation. About 10 to 20% of STIMI patients have no typical elevation on the ECG. You can think about a bundle branch block, it is the left, but also the right bundle branch. Ventricular pacing, isolated or universal ST segment depression, and also hyperacute T waves, which are called the so-called De Winter T waves. A colleague of mine from Amsterdam demonstrated, which is named after him, and demonstrated that it's associated with a proximal LAD occlusion, which you can see here on the angio. The LAD is blocked, and it is present in about 2% of all STIMI patients. Further, you can see it on this ECG. There's a junctional ST segment depression and a tall hyperacute T wave. And so this patient should go to the primary PCI center. Also, what do we know about gender differences in STIMI? Well, we know that women have an increased patient delay, also related to different symptoms. Furthermore, an increased overall ischemic time compared to men. They receive less evidence-based treatment, and they have a higher shorter and long-term mortality after primary PCI. And this is demonstrated in several large registries from France, UK, and Sweden. However, we have a little knowledge about the different time frames in system delay. That's why, and it's important to demonstrate some data from the Amsterdam triage system. We have a very well organized pre-hospital triage system. This is Amsterdam, and not Amsterdam city alone, but it's all the environment. It consists of an area about 700 square kilometers, and it consists of about 1.3 million inhabitants. And 3 primary PCI centers are there, which is the OVG East, the AMC VU, and AMC. And we are one center now, and it's divided by a zip code. So the ambulance is going to all the different PCI centers. Very recently, we published our manuscript in the Netherlands Heart Journal, and about the evaluation of the sex differences in STIMI patients. And I will bring you to this slide because it's a very busy slide. But the bottom line is that you can see here the patient delay, the system delay, and the total ischemic time. And all the different time frames you can appreciate here. These are the women and these are the men. And in the bottom line is, in the end, is that there's no difference in all the different time steps between men and women. Patient delay, 51 minutes, system delay, 94 minutes, and total ischemic time, 157 minutes. Furthermore, if you look at the percentage of patients diagnosed and treated within 90 minutes, it is about 70% in both genders, including out-of-hospital cardiac arrest, and 85% in both genders without out-of-hospital cardiac arrest patients. This is a good percentage. And it's comparable with also a recent published paper from Sweden with data from the Swedish Heart Registry. And if we look at the 30 and 1 year mortality, there are also no differences between men and women. So we can state that in our manuscript and in Amsterdam, there are no gender differences at this very moment. We think women and men are aware of their symptoms, and also the pre-hospital triage system is aware of equality between men and women. So I want to conclude that the reduction in system delay in STEMI patients is very important for the reduction of mortality and morbidity. Furthermore, regional triage network system needs to focus on special things like ECG, bypassing non-PCI centers, 24/7 availability of primary PCI centers, focus on presentation in off-office hours, and furthermore, of course, gender equality in treatment must be there. Thank you very much for your attention.